And I just wanted to tell everybody, including the potential physicians who are listening to this, that this kind of data is being accumulated every day. There are multiple studies that are carried out by institutions in the US and abroad that basically doing exactly that. They're calculating polygenic risk score, they're returning this information to doctors, to patients. They use it in clinical care every single day.
What do doctors need to know to be able to implement genetics into their clinical decision making and things like polygenic risk scores and integrated risk scores? And I would say not that much. It's kind of a rudimentary knowledge about what the testing is and what it's telling you, what it's not telling you, how reliable is it, how likely it is that it's significant in a given situation.
Welcome to the Precision Medicine Made Simple podcast, where we simplify the complex world of precision medicine. We're here to explore how personalized healthcare can empower you to understand and improve your health to live a longer and healthier life. Join us as we break down the latest in medical science into actionable insights. Let's make precision medicine accessible and actionable for everyone. Enjoy the show. Today's episode is sponsored by Biography Health, where healthcare meets personalization. With their DNA-enabled blueprint, Biography Health empowers you with a health plan based on your unique DNA, aiming to prevent disease and extend your life. Take control of your health journey with a plan as unique as you. Visit biographyhealth.com and start your personalized healthcare journey today. As a reminder, this episode is for educational purposes only. This episode is in no way a replacement for professional health advice. Please consult with your professional primary care provider for medical advice. If at any point you feel that a topic discussed on our podcast was misrepresented, or if you have additional insights that could enhance our discussions, we wholeheartedly encourage you to reach out to us. Your feedback is invaluable in helping us improve and in ensuring our content remains both informative and reflective of the latest developments in precision medicine. In this episode, Dr. Yelena Bykhovskaya, Chief Scientific Officer at Biography Health, shares her expertise in genetics. We explore the importance of both polygenic and monogenic risk scores in patient care. The conversation underscores the value of combining cutting-edge genetic analysis with traditional clinical factors in the evolving field of precision medicine, emphasizing the need for a more comprehensive approach to patient care. Hey everyone, welcome to the Precision Medicine Made Simple podcast. I'm here joined with my co-host, Dr. Stanford, and we have a very special guest today. Today's guest, she's a leading expert in the field of genetics and precision medicine with an impressive background that spans groundbreaking work in genetic testing for complex and Mendelian eye diseases. Her research has led to major advancements in mitochondrial genetics, including discoveries in maternally inherited deafness and other rare disorders. She's held prominent roles at Cedars-Sinai and Avellino Labs, where she develops innovative genetic tests through national and international collaborations. Now serving as the Chief Scientific Officer at Biography Health, please give a warm welcome to Dr. Yelena Bykhovskaya.
Thank you so much, Taylor. I'm excited to be here. Thank you.
Yeah, welcome. And so just to kick off this podcast episode, I'm curious how you and Dr. Stanford actually connected beforehand, because y'all have some history before joining Biography Health. So I'd love to hear that story.
Well, absolutely. I think it's a great story. If we were married, it'd be a great story to tell our kids. Okay, it's not. Well, it's what happened is that I really got interested in precision medicine, and it's a very up and coming topic, and I basically did a search on LinkedIn, and Dr. Stanford's name came up. And when I reviewed his credentials and his statement and his place of work, I realized that he is truly is a person to reach out to. So I did. And I sent him a message on LinkedIn. I don't know how many messages he gets on LinkedIn every single day. And my guess is probably more than one. But for some reason, he replied to me within 30 minutes of me sending this message. And I replied to him within 5 minutes of receiving his message. And then we had our first Zoom meeting the next day, which was actually Saturday. So both of us found in our, busy weekend schedule some time to talk. And after we talked, we also realized that we so much in common and common intentions and interests. And so we started talking and we met, and I started doing some work for his company, BHIPM, Beverly Hills Institute of Precision. And he asked me if I wanted to join Biography Health. And I said yes, because it's a great company, and I'm very excited and proud to be a part of it.
It's an honor to be a part of the team with you. And so, Dr. Stanford, I'm curious then, in responding to this DM and then now working with Dr. Yelena here, was there something about her approach to genetics that really caught your fascination then in wanting to bring her on board to help you in her practice and how she was looking at the data?
Yeah, there was so much in her past work history, especially the most recent company that she was with, that it was exactly the expertise we needed. And then meeting Yelena and seeing her great communication skills and the ability to break complex things down so I could even understand it. It was huge. And she has brought all that to the team, and especially everything she's learned in terms of how to go about evaluating polygenic risk scores, how to put together a report which blends clinical factors and genetic information into a firm set of recommendations. That's exactly the kind of expertise that we needed from a geneticist. And so it was a perfect match from the get-go. And thank you, Yelena, for noting I responded. So I saw very quickly that she was a perfect match. So I'm going to take credit for that. And that's why I didn't want it to, I didn't want to let any opportunity slip by. So we jumped all over it. And I would say we had you signed and sealed and everything within a couple of days, right? So
yes, I started working within a couple of days. Yes, it was fantastic. It was like a miracle, honestly, because usually the interview processes they could take forever, and it was very refreshing. And yeah, I think this is the perfect match, and I'm glad you think so as well.
Yeah, and I would love to sort of just extrapolate what working together looks like, because I think this is pretty unique. Not very often you see doctors working with scientists, and I mean, coining the term physician scientists. And so when you were, so Dr. Stanford, were you taking a look at this genetic data first beforehand, at all yourself, and doing your own research before Yelena came into the picture then? Like how, and she's the one that really elevated your operations to be able to look at all these. Okay.
So I've had some specific coursework in genetics. That's different than essentially having a PhD where you worked in genetics and 20 years of experience in it. So I have more than the average background in terms of genetics for a physician, so so that's great news. But I also realized that I don't really have the expertise to fully vet and apply scientific rigor to evaluating the quality of some of the testing and reporting that gets done. And so to have someone that is a specific expert in that is really critical if you're trying to move the field of medicine forward in terms of implementation of precision medicine. Because like I tell my team all the time, doctors can be, they're pretty serious customers. They want stuff that is evidence-based and holds up to scientific vigor. And the same with regulatory bodies like the FDA or say the American College of Physicians. They want to know that what you're doing has a strong scientific basis. And the way that I approached the Beverly Hills Institute for Precision Medicine from the beginning is I wanted everything to have as much scientific vigor as possible. The follow on to that is when Yelena came on, there were some things that I was doing right, a few things, and there was a lot that I was doing wrong from the standpoint of, this lab you're using, this report you're including, doesn't really meet the standards that you're asserting you want to have in terms of being able to withstand a critical view that you're going to get from the scientific and medical community when you go to set out to do what it is we're trying to do, which is personalize our patients, find out exactly what makes them unique, what about them in terms of their past medical history, family history, and genetics, and then shaping that background into specific recommendations about how to avoid, prevent chronic disease so they have the longest health span and lifespan. So she was able to point out in relatively quick order there were certain things that I would want to continue doing and certain things we would not want to include in the report. And that's when I thought, better than just our geneticist, you need to be our science officer. So that's Yelena's job, is more than just the genetics, but making sure that what we're doing can withstand scrutiny, because that's a big part of what holds the field back, the field of precision medicine.
Absolutely. And I just want to say that this is exactly what I want as well. And that's what I always wanted when I was doing research, when I moved to industry and we started doing genetic testing. It has to be done right. It has to be done based on science, strong evidence. And this is my job, and this is my intention to continue doing that in the field of precision medicine as well.
Now, something that was brought up in a conversation offline that I was very intrigued with is the difference between genetic risk and family history. As dumb as this statement might be, it almost seems synonymous in a way where it's like, oh, well, if you have a family history of it, then you can just say that you have the genetics for it, right? But something that I found profound from that offline conversation was the difference was how it's measured. And so I was wondering if you could tell me more about that and what that relationship, like what the key differences between the two of them.
Sure. So the way I see it and the way it presents itself is that your genetic risk is what's being measured and analyzed in your DNA. So we can look at your mutational load. We can look at your what we call polygenic risk. I think we will talk about it a little more, and we can assess that for you personally. But but your family history is kind of a history of how that genetic risk presents in your family. And that also includes perhaps some environmental factors and other factors that perhaps even epigenetic factors that we're not really assessing when we're measuring specifically genetic risks. And so when we look at things, and this is what precision medicine is about, you take different things and you put them together. So let's say you have a high genetic risk for, let's say, breast cancer, right? Or I mean, not you personally, but somebody has a high genetic risk for breast cancer. But in your family, you have individuals who have had a cervical cancer, right? So that means that in your family, that risk kind of changed itself and, is modified somewhat by some factors to be different. Okay, you still have a risk. So both of this, but what happens is that does not necessarily mean that you will develop patient will develop either breast or cervical cancer, but we want to know about those risks independently, so you can get screened. The person can get screened for both cancers in a timely manner, and identify those cancers before they become uncurable. So that's why Dr. Stanford takes literally hours collecting those family history, and we do a comprehensive independent analysis testing for the genetic risk.
Yeah, and what I love about what you were saying is that it's dynamic then, right? I mean, like it almost feels like family history is sort of the tip of the iceberg, but then there's all these other factors that are underneath the iceberg that can then lead up to, let's say, an increased risk for this or an increased risk for that. It doesn't necessarily mean that it's inevitable that you're going to be getting this type of disease or cancer.
Well, first of all, I want to stress out that, there's literally no genetic risk or very little genetic risk that's inevitable. Okay. Most of genetic risk comes with probabilities. For some of it, it's really high. So at the end, it's not 100%, but it's approaching those values. And so it becomes truly a strong determinant of your health, right? But most genetic risks are just not as decisive. And so there is the environmental factors, there are something called genetic modifiers. And like I said, it's what the risk looks for you with your family history and whether this genetic risk already presented itself. All of this is kind of determines what your lifetime risk is. So your lifetime risk is a combination of your genetic risk, of your family risk, comes from family history, of your clinical risk. So that's probably one of the biggest determinants, and also of your environmental interactions and risk. So it is a combination, and this is something that everybody should know about.
Yeah, and so when we're speaking about learning, well, I guess use the term genetic analysis then, and this is also stemmed from a conversation that we had offline too. I didn't realize that there were differences in how we were analyzing our genetics. Like there are different types of processes, different sequences of doing so. And I was wondering if you could expand on that, and then leading into ultimately how then, well, let's start there. Let's start there. Like what types of genetic analysis is out there?
Sure. So for a long time, the type of genetic analysis that was available to patients was basically a single gene sequencing when they were suspected of having a certain genetic disorder, right? And that genetic disorder, like Down syndrome, for example, right? Or cystic fibrosis, right? So when the cystic fibrosis gene was discovered, then anybody who would show up with that symptoms, they would take the gene, sequence it, and look for mutations. And mutations are changes in DNA that are detrimental to the function, right, of the protein or that leads to the disease. But then a revolution happened, and that revolution is called Human Genome Project. So human genome has been sequenced. And so we found out first of all, how many genes they are and what these genes are. We might not have known all their functions, but we knew they were there, right? And we also found that there is something called the non-coding sequence, right? That's a part of human genome, and perhaps the function of it is not known, but there is but that's the part that's actually very variable between individuals. So this variability in DNA, it can be assessed by analyzing the non-coding DNA, okay? So then something called the genotyping came across, and genotyping basically is taking the positions in non-coding DNA.
What's the difference between non-coding and coding DNA? I feel like that's such a basic question, but
that's a great question.
Okay. So the small proportion of DNA codes for something called gene. So genes code for proteins, and proteins make the pathways, and they make the membranes, and then that's something that kind of works in our cells, right? So that's what genome is about, to code for the proteins, that that's its biggest function as far as we know, right? So all genes together are called an exome. Okay, so genome is like all of the sequence, coding sequence and non-coding sequence, right? If you just take a coding sequence, that's your exome, and that's about so the genome is 3 billion base pairs, right?
Okay.
So then the exome is 60 million base pairs, right? But there's also a way to look at the genome at a very certain positions and, something called the genotyping, and still be able to do some risk analysis. Okay, and like I said, all of this became available with the completion of human genome in 2003, and then going forward and doing a lot more work, to understand all of those things about the genome. So the first company that started doing genotyping for assessment of human disease or any kind of risk is 23andMe, right? So that was in 2007. That's when the company opened. And I really credit them with bringing the genetics into the masses. Before, no one knew that you can actually, look at your DNA and have somebody tell you something. So like I said before, only people with genetic diseases had their DNA analyzed, and only for very specific genes. And that was a very niche, right? So with 23andMe, there's people who, walk the streets of all walks of life, who all of a sudden were talking about their ancestry, about risk, and about genes. And so all of this, I think, brought understanding or more understanding about genetic risks.
Yeah, and I think it's pretty fascinating that it sort of opened up the door to have more conversations about genetic risk. But to make sure that I'm fully comprehending what we've been talking about here, it almost sounds like genotyping then has its limitations. Then, if you're going to be comparing it to like whole genome sequencing, where you're taking a look at all the different genes, whereas genotyping, you're only looking at a very specific, like almost just the positions of these genes. The information is limited. Then, like, can doctors still use the information from just genotyping instead of whole genome sequencing? Like, what does that look like?
So all information, the comprehensive information about genome is useful, but every method has its limitations. So the genotyping, limitation of genotyping is that you only look at certain positions that are preset on your genotyping chip. That's a limitation of the technology, okay? When you do sequencing, you look at every position that you sequence. Now, the sequencing could also be limited to something called the exome, right? Like I said, if you only want to look at genes, you don't want to look at any non-coding sequence. And some people are, there's some reasons for doing the exome sequence, okay? Then you will be only looking at the coding portion of the genome. But the golden standard and the most comprehensive approach is to do a whole genome sequencing, where you get everything. So then the data is limitless. It's just your analysis of it is what limits you, and that depends on the purpose of whole genome sequence. So for precision medicine, this is how we use whole genome sequencing data. It's actually quite easy. Okay. So we'll look at non-coding sequence to identify polygenic risk. Okay, because the polygenic risk is basically determined, that's just methodology of it, by using the variants mostly from non-coding sequence. Okay, and then we'll look at the coding sequence to determine the monogenic risk, which is mostly, again, and I want to stress that, the word mostly, not all of it. Not all of polygenic risk comes from non-coding sequence, and not all of monogenic risk comes exclusively from the coding sequence, but the majority of it. So we separate it and we look at it separately, and then we put both together into one report. Okay, there's your monogenic risk, there's your polygenic risk. So now you know your risk that comes from both sources.
Yeah, and go ahead, Dr. Stanford.
Yeah, I was going to say, I'm glad I'm listening to this podcast today because I just learned something.
Right. Yes.
I did not realize that the majority of the SNPs, so to speak, that go into polygenic risk scores are in non-coding regions, either the regulatory parts or the introns, the part of the gene that actually doesn't get coded into the protein. I didn't realize that. I thought it was, a mix of exome. That's the stuff that gets coded into to amino acids and protein. I thought it was a mix of that and the introns and regulatory stuff, but I would have lost a bet on that. So thank you, Yelena. You taught me something yet again.
Well, I'm very glad to do this. That's why I'm part of this, and I love to be. And I have to tell you, it's something I learned as well, because the more people do whole genome sequencing, they discover more variants in non-coding regions that are actually monogenic, that are actually lead to genetic disease by themselves. So, like I said, this is why I want to stress the word majority versus all, because in no way they're all. So this is a very fast moving field, and we really are on foreground of it. And I look at the literature every single day and I get updates, and it's very useful. So it makes us the best choice because we're keeping up. We're constantly improving and constantly on top of it. So it's and you have to be, because we're not AI. So like I said, AI probably moving even faster because a lot of people are invested in it, but definitely genetics is right behind it.
And so with providers then that are looking to try and implement and integrate these genetic insights into their practice, then what do you think is something that they should understand first to help implement these insights then? Is it really trying to understand monogenic and polygenic, and then those two then are integrated into the care plan? Like, is that more of like the foundational reasoning as to what they should know?
Well, the one thing that I think I want every provider to know is that people who carry monogenic variants, and I know that a lot of people learn that in their genetic courses, right? So when you study medicine, you do have a genetics course, right? Let me tell you, I have a nagging feeling that even now, the analysis of polygenic risk perhaps hasn't found its way into the genetics courses, or majority of genetic courses in medical schools. Okay, and it's a huge shame, because what doctors don't realize is that people who are outliers and who have a really high genetic risk, they have the same risk level of developing a disease as people who carry the monogenic variants. So the way that they think about it is that, oh, well, if we have the mutation, right, like BRCA1, like BRCA1, BRCA2, the highly penetrant mutations, then okay, so now we know this person is going to develop breast cancer, right, or has a high chance. Well, guess what? If there's another person who doesn't have the mutation, but has a top 1% of their PRS score for breast cancer, they have an identical chance of developing a disease. And that's not just for breast cancer. That's the same for atrial fibrillation, for coronary heart disease, for open angle glaucoma, any disease that has a well-developed PRS score, right, polygenic risk score. People who are outliers, who are in top percentile of those scores, are basically as likely to develop disease as people who have the mutation. So this is then the conundrum for the provider. If you only look at the monogenic variants, you're missing a lot more individuals who have the polygenic risk. And if you only look at polygenic risk, then you are missing the people who may have monogenic variants, and you really want to look at those people. So at the end, your course of action is going to be similar. It has to be the same whether you've identified a carrier of a BRCA mutation, okay, or whether you identify an outlier, top 1% of polygenic risk score. You have to send them to a specialist, right? If you're not a specialist yourself, okay? So they have to be tested, they have to go through testing, and they really have to know about that genetic risk, okay? For people who are not in that, like top categories, who just have increased risk, that's important too, okay? Or decreased one, right? Because if you have an increased genetic risk for a certain disease, that's where you concentrate. This is where you going to put your efforts. This is what you're going to try and mitigate before it becomes a full-blown disease, right? And if something, and if you're at lower risk for something, then perhaps, low risk is a trickier category, but the high risk or increased risk, there's nothing tricky about it. You just have to go over there and you have to work it. You have to face it. You have to acknowledge it, and you have to have someone like Dr. Stanford help you understand that no, this is not inevitable. But if you don't do anything, right, it will become. So this is how I think is the way to look at it and to act on it. Just help your patient do the best and provide the best care to mitigate the risk.
I can add a little bit
Please.
To that, or just to add a definition, a term, so to speak. So when we talk about above average risk, sometimes we use the term elevated risk or high risk. That means it's your chances when you control for ethnicity and gender, your risk is greater than 2 times the average risk. If you're less than 2 times the average risk, we call that average risk. So even low risk, we call average risk. And the reason we just have that cut point at 2 times the ethnicity-wise and gender-wise controlled risk assessment is that you can generally apply those population scale guidelines when you're at average risk, or certainly less than 2 times risk, or if you're very low risk, we can go with those population scale guidelines. But if you're at higher risk, you're going to want to be more vigilant, most likely, than the usual population scale guidelines call for. So the idea behind all this, which Yelena was detailing, is you find those areas where you're at increased risk and you intervene early and do things like lifestyle interventions, sometimes medications, sometimes supplements, and you try to prevent, slow the onset of those diseases, and sometimes you can prevent them altogether. And if you can't prevent them altogether, you want to be vigilant and catch those chronic diseases just as the person is transitioning from the healthy state to the disease state, because that's when those diseases are most easily treated. So you want to catch that vascular disease before the heart attack or stroke, and you want to catch cancer either in the precancerous stage or stage 1 or stage 2, not stage 4, because in stage 4, cure rate's 10 or 20%, generally speaking. And stage 1, it's more like 90%, 95%. So just to define those terms.
Well, thank you. Thank you for clarifying that. And this is why I think we're such a great team, because you provide the clinical the clinical course to what genetics tells us, and this is the best way to go about it.
And so for my understanding then, and so you have your monogenic risk score, you have your polygenic risk score, and then now you're trying to prioritize what is most at risk and then attack whatever is at risk from there of what's considered elevated risk. Now, one thing that this is kind of just clicking in my head right now, with monogenic risk score and polygenic risk score, you mentioned that one doesn't really outweigh the other in terms of significance or importance. You kind of have to look at both of them equally. But then is that what the integrated risk score then really comes into play? Is because now it includes and culminates the monogenic, polygenic, and then the environmental and then lifestyle factors to then say this is where their integrated risk score is for X disease. Am I correct in this understanding?
Well, you are, except that genetics is even more complicated than that. So yeah,
Okay.
I know. So there's
Surprise.
right. And to be honest with you, I have to bring it up here, but also you have to understand that the knowledge is not limitless, right? So we've only known human genome for what, 20 some years. So we're still learning, and there's papers being published every single day, and they all trying to clarify all those questions that you ask, right? So what is how do the monogenic variants and polygenic risk interact, right? And so we know that there is some diseases where they complement each other. So that's your monogenic variants. They're even worse when you have a polygenic risk score, okay? But not necessarily. You can have a completely independent polygenic risk score with no monogenic variants to go with. So this is where the comprehensive analysis comes in. So basically, you look at the both types, and you determine which ones are of worry, like which ones are really high, which ones bring your risk really high. So that's the ones that you're going to address. And like I said, they may complement each other or not. It doesn't matter. It's you can look at them independently, and you can look them together. If you see that they coincide, then that means that it's even worse. Okay, but if they don't, that doesn't mean anything. The risk comes independently. We'll analyze it independently. Okay. Does that answer your question?
Yeah. And then it also brings up even more questions now.
Can I chip in?
Okay. Go ahead.
Let me chip in another definition of terms there. So you mentioned integrated risk scores. When we talk about integrated risk scores, we're talking about polygenic risk scores that are integrated with clinical factors that find their way into certain risk models. So for example, if you're trying to predict the risk of a cardiovascular event like heart attack or stroke, there are risk models aside from genetics, things like what's your LDL level, what's your blood pressure, are you taking medications for lowering the cholesterol, lowering blood pressure, are you, what's your BMI, are you diabetic? So those types of questions, clinical factors, can factor into predicting risk. And of course, your genetics, the polygenic risk score, independent of those clinical factors that we observe, can go into predicting risk. When you combine those risk models independent of genetics and the genetics independent of the clinical factors, when you combine those things, we call that the integrated risk.
I just wanted to add something to it. So you said that there's these models for polygenic risk scores, but guess what? There are these kind of models for individual monogenic variants as well. A number of BRCA mutations come with those predictive scores as well, because they've analyzed the carriers of these mutations, and they correct for ages and gender, ethnicity, and all of those things, and perhaps the age of menstruation and things like this. So it's not just the polygenic risks can be modified by the clinical factors. that monogenic risk can also be modified, and that it can
Absolutely.
also be assessed.
So with the comprehensive analysis then, and I mean, you mentioned the different types of risk models and how they really all come together then. If a provider is looking to try and implement this into their practice, it almost seems pretty I mean, I'm not a provider, I'm not a doctor, but it does seem overwhelming to try and integrate something that they, let's say it wasn't as in-depthly covered in school then. So like,
So
where should they?
Let me speak to that a little bit. So as doctors, we do that every day right now, even without genetics. So taking the next step and doing it with genetics shouldn't be that tough of a bridge to cross, so to speak. So for example, patient comes to us and the question on the table is, do they have a urinary tract infection? Well, there's all kinds of information that we look at that will draw us into thinking, yeah, they have a urinary tract infection that needs treating. No, they don't. So first, do they have symptoms? 2, do they have white blood cells in their urine? 3, do they have fever? 4, do they have a history of recurrent urinary tract infections? Did they just recently have one? So there's all these different factors that go into weighing whether or not we believe the person has a urinary tract infection that needs to be treated. So I would submit the same thing. And you call that approach kind of what we call a Bayesian approach, which is you may have a prior estimation of the risk of a given thing, and then you get these additional pieces of information that are kind of weighted, so to speak. So in other words, you're looking at, number one, how reliable is this data? Number 2, how important is it in predicting whether or not someone has a certain disease state? And 3, what's the patient look like? And then at the end of the day, doctors don't treat numbers, they treat patients. So there's all these factors that we integrate together already to that drives our clinical decision making. And I would submit, and I've yet to have an argument from a doctor about this, is that genetic information and genetic risk is just one more thing that we integrate into our clinical decision making. And again, we weigh that, so to speak, with Bayesian type logic.
Well, and not to put you on the spot here, Dr. Stanford, because I think there's something key in that bridge and trying to integrate then this other factor. Then, like, what does that bridge then look like in terms of like thought process and I guess risk modeling then?
So I'm speaking of integrating, I'm going to integrate your question from about 2 questions ago into the answer.
Okay.
And that is,
okay.
That is, if you want to be good at something, you need, so, I mean, you can generalize it to just about anything, but let's go back to the practice of medicine. If you want to get the most out of that information from a test, no matter what kind of test it is, you need to understand that test. How is it done? What are the limitations? Why might it be wrong? Why is it probably right? Et cetera, et cetera. So you need to have some basic understanding of the test and what the result might be telling you. And then, of course, a feel for the probability that the result is significant, et cetera. So I think a couple of questions ago, you were touching lightly on what do doctors need to know to be able to implement genetics into their clinical decision making, and things like polygenic risk scores and integrated risk scores. And I would say not that much. It's kind of a rudimentary knowledge about what the testing is and what it's telling you, what it's not telling you, how reliable is it, how likely it is that it's significant in a given situation. Obviously, if you've done a couple hundred cases like I have, you're going to have a better than average sense of doing that. If you haven't had much exposure to genetics since medical school, it'll be more difficult. So I think that what we're going to see is, I think to practice medicine in the future, really now and anywhere in the coming years, you're going to have some basic understanding of the science behind some of these new approaches, or else you're going to be stuck in the way that medicine was practiced in 1995, which is far, far less effective than what we're able to do now. So if you want to practice the medicine of today and of tomorrow, there are a few things you're going to have to familiarize yourself with. And I think that people like Yelena and our company, along with other similar companies, we have to get out there and help educate doctors to a minimum level about how to use this information to help give their patients a better care plan. And it is a little bit of a tiny bit of a heavy lift when you're talking about how drastically it changes the approach, even though it's just one more element. This element, though, is so powerful. When I say the element is genetics and epigenetics and proteomics and all these things that allow you to be predictive. So what I'm really talking about, what we're all talking about, what hundreds of doctors and scientists are talking about, is using these tools of science to understand where a patient is at in their health span and what their risks are. So it's a move from being reactive to being proactive. So we can be predictive, so we can be proactive. The current healthcare paradigm and be preventive. The current healthcare paradigm is really just to wait till something bad happens, because that's when insurance will cover whatever it is that's going on. And we react to that and do the best we can. But as I said, that's so 1995 and so not where we are in 2024, almost 2025.
Well, I have to say, 1995 isn't that old either, just because I was
Thank you.
born.
Thank you.
I was
Thank
born in
you.
Oh my
1995.
God, this is ancient.
Thank you. That was when I
Okay.
graduated from medical school. So
For
I didn't
genetics,
just pull that number out of thin air.
for genetics, it's truly ancient. That's when I started my genetics training, and then it truly is ancient. It's a world between now and 1994.
Right. So I took genetics in medical school in 1992.
Yeah, it really is a different world. And you know what? To address that, I just wanted to add something that I really don't want to discount the physician skepticism and toward polygenic risk, because it is so new, right? So they're expecting, they want the level of evidence for polygenic risk as they have watched, develop for the monogenic risk. And I just wanted to tell everybody, including the potential physicians who are listening to this, that this kind of data is being accumulated every day. There are multiple studies that are carried out by institutions in the US and abroad that basically doing exactly that. They're calculating polygenic risk score. They're returning this information to doctors, to patients. They use it in clinical care every single day as a part of precision medicine research. Okay, so this is still a part of mostly research, but what they're seeing and what's being published, and I have references, I can provide those, that every single time that kind of risk is determined and disclosed, there is a positive outcome. So there's positive outcomes for gaining additional care. There's positive outcomes for less heart attacks and so forth. So there's no negative feedback or negative outcomes that have been shown for any of the polygenic risk or score that been used in practice in research. And again, I just want to stress that more than research, because bringing it to clinical care is a new thing, and I am very excited to be able to do that, because this is not the future. It should be now, and it should be done today, and it's been done already, but by Dr. Stanford. So our job is to make sure that we use the best tools for calculation of those risks, that we correct for ethnicity, that we correct for, things that we can correct for, that these models that we use are the most up to date, and that the scores we return to providers are the most accurate scores that we can produce and deliver. Okay.
And make sure you're looking at things like polygenic risk scores in the context of the patient, the person themselves. So
absolutely. So yes. So recommendations is a next step that includes the scores as well as all the other things that, clinical and such.
It's just that risk just signals to the provider to be more vigilant and to take a closer look. It doesn't mean, and just back to that analogy with UTIs, you don't pivot all your care around one number or one factor. You have to look at it in the context of the entire person holistically.
Now, because I agree with understanding the research and following the science, and really just with the scientists are sort of leading the way to help implement precision medicine into clinical care. On the other hand, though, and this is maybe more of like a challenging thought that I was thinking about while I'm not a provider, but something that clicked that when Dr. Stanford was saying is what providers really want to know is just the context behind the certain tests that they're going through. That's where I can imagine some of the skepticism. If they don't understand it, that's why they're not going to do it then. Right? Is that?
Yeah, no, well, absolutely. And that would be great. Meaning if you don't understand how to use the information from a certain test, you could make a pretty good argument. You might as well not get it. On the other hand, if you could obtain that understanding fairly easily and you can improve the quality of the care you're giving, then probably should go ahead and try to have that increased understanding.
Right. Because I think this opens up another conversation then that we really haven't talked about. Because, I mean, we've all been speaking about just the power of precision medicine, but something that we haven't really brought up on this show is the skepticism behind using, let's say, some of the genetic data that's out there in certain case studies. And so I was wondering if we can open up that conversation and talk through some of the skepticism that's there I guess address it.
Sure. So the skepticism that I've faced for the last several years, since I personally worked with my team to develop some of those polygenic risk scores, and then I truly wanted to bring them into clinical care, is the fact that the genetic studies that have been used in generation of a lot of those polygenic risk scores are limited to individuals of mostly European ancestry. So that's a fact, and I will not, argue with it. It is a true occurrence. So I'm one of the geneticists who chose to limit the populations that I've analyzed in my genetic studies. But I have to kind of be honest that it has nothing to do with me being racist or nothing like that, or trying to limit my findings to some population. It's just the nature of genetic analysis. So there's something called a heterogeneity, genetic heterogeneity. So when you mix people of different ethnicities, you basically add a lot of different influences. We all know that we're same and yet we're different, right? So the genetic variability genetic variation is what makes us unique, but that's also what makes genetic studies very complicated. When you bring different, ethnicities in, you basically lose the power. The power of genetic studies is something that lets you identify things. These are the things that you can see, that you can see their significance, right? And if you can't see it because your sample is mixed, okay, then you will never see them. So then what happens is that the initial studies were limited to European populations. They found some very important determinants of risk. And then now we can use those determinants and evaluate them in different ethnicities and see whether they have the same influences, or do they have similar ones, or do they have no influence, right? So this is what's again being done, and being done, not just being done, it's been done, and it's being done. And so that all improves the power, and it addresses the issue of racial, inequality, or being able to do. This is something that I mentioned before. So being able to provide the most accurate score for every single patient of every ethnicity. So there are multiple ways of doing it. And like also, as I mentioned, this is a continuous developing field. There are tools that have been established that allows to correct for patient ethnicities, and again, make the score more consistent with their ethnical background, right? Ethnic background. So all of these tools now make polygenic scores are better, more accurate. And so it's a very positive thing that's happening every single day. Perhaps something that some of the doctors who've heard the headlines and aware of this flaw, if you want to call it, in the field, have heard. Well, I want to let them know that we know about it. This has been corrected for a number of diseases, a number of so I don't want to say it's no longer an issue, but it's not an issue big enough to ignore and to say that this should not be used. Okay, so this is my opinion that it can be used. Again, in a matter that Dr. Stanford, brings over and over and over. This is a piece of the puzzle. You get multiple things, you get multiple measurements, you get multiple patients, and you just use this as one of the risks and one of the pieces of information.
I so I have a question for you, Yelena. So with like ApoE4, I mean, this is a really important case in point, is that not every, just because you have a certain risk allele doesn't mean you're going to get the disease. And especially in terms of controlling for ancestry, et cetera. Now, correct me if I'm wrong, but the ApoE4, the risk allele for Alzheimer's disease, there's a high prevalence of it. Is it Nigeria?
Africa? Yes, in African
and
population.
Almost
That's
zero
right.
dementia.
That's correct.
Whereas that same risk allele in a Caucasian population is a number, but guess what? Even more in a Caucasian female is again even higher risk than a Caucasian male. So you can't look at these things in isolation across the entire global population. So it affects different genetic risk, affect different ethnicities and ancestry and gender in a completely different way. So so Yelena got it just right. It's one piece of a much bigger puzzle. Anytime you're a doctor, you're treating people. You're not treating numbers or letters.
Yes.
Now, Dr. Stanford,
that's
did you ever?
Very cliche. I mean,
that's tweetable.
Cliche of the week, right there. but it is true.
Now, Dr. Stanford, I can imagine you also had some skepticism jumping in, or maybe was there any specific skepticism that you had in terms of any studies?
So actually, I had kind of a reverse experience. So when I first decided to pivot into precision medicine from hospital medicine, some of the first types of numbers I came across was the percentage of people that would have a pharmacogenetic actionable recommendation, or how often someone would have a gene variant in the American College of Medical Geneticists, 72 genes that they felt worthy of comment. And the numbers were, like, I don't know, 10, 15, 20%. So when I went into this, I was wondering, hoping that I would have something like, 20 or 25% of people that I would find something that would change their health trajectory. What I found was that number is like 95%. I swear that well in excess of 9 times out of 10, I'm going to say 19 times out of 20, there is some significant thing that is found. And I don't mean a single gene, but maybe a polygenic risk, or maybe something that's even just buried in the past medical history when you look at it in the context of family medical history and genetics, that having that knowledge will and acting upon it will likely change how the duration of the patient's health span and probably lifespan. So I guess I was a little surprised at how impactful this could all be.
Absolutely, because of the comprehensive nature of what we're doing. Because if you only look at the carriers of monogenic variants, I think it's 0.5% of population. So imagine that some people would never see those, So that's why the patients get the reports where it says that nothing was found, nothing. But there's a difference between finding nothing and looking at the comprehensive genetic picture and actually finding things. So this is what we want to do.
And you have to blend internal medicine with the genetics and with just good old-fashioned doctoring and sleuthing and piecing it all together. And normally that would be a pretty labor-intensive thing, and it was. So for the first few years, I was doing that, very labor-intensive. And now to have some automation and maybe even some algorithms that help find recommendations, I would say draft recommendations in a structured way, it really has taken a lot of that time out of it. There's still the clinical decision making and physician scientist piece of looking at those recommendations and saying, yeah, there's evidence to support that the benefit outweighs the risk in terms of, say imaging or some kind of treatment. Yeah. So you definitely have to look at the entire picture and go with that.
And I'm very excited to be able to do that because Biography Health actually is a platform that gave me this opportunity and to do things that are difficult and and be able to do this comprehensive analysis.
You know what you two are like? You two are like Michael Jordan and Scottie Pippen.
Is that a good thing? I'm sorry.
No, that's a good thing. That's a good thing.
This is lost on me.
They won championships together.
Okay,
I'll let you decide who's who.
Yeah, we should decide.
I'll let you two decide who's who.
I think Yelena's husband is kind of a sports fan, so he probably saw the Jordan series. So,
no, I know who Michael Jordan. I know who they are. I just don't know what their relationship was like.
Well, it was a little rocky. Let's just say that.
Well, not the rocky side. Not the rocky side. I was saying more in terms of the winning championship side and working together as a team to win the championship. Because that's what's like really unique about this relationship, and even with this podcast, is the how you two work together and collaborate. And it's really just this cohesive understanding of trusting the science, learning about the science, and being able to implement this into clinical draft recommendations or medical advice. And so, I mean, from both of your perspectives, do you see more providers then in the future having their own Yelena or having their own?
Yeah, I can't wait to comment on that. So I think that I'm going to give myself some credit and say that I can be very honest about what I don't know and have enough insight to know that there's a lot I don't even know about what I don't even know. And trying to do this, blending these sciences of genetics and personalized medicine into an internal medicine background. Having that quality, I think, has helped me a lot to take advantage of someone who is expert in those critical pieces of the complementary part that, yeah, like I said at the top of the podcast, I know way more than the average doctor, but not nearly enough to have scientific vigor and be able to array the evidence-based support for what it is that we're doing. So having someone kind of humbling yourself a bit and having someone step in and provide that has been a sea change in our ability and my confidence in how we're going to move this thing forward. And I guess to get to your question is every what is it? Is every Tom Brady going to have a Belichick, or is every Jordan going to have
A Pippen?
Pippen? Is McCaffrey always going to have a Shanahan? And so we can kind of go on and on, but I think that and you touch on, speaking of not knowing something you don't know, but doctors can be the type of personalities, and it mainly because they're CEO of this very important company, which is responsible for the health of their patients, the employment of their nurses and medical assistants, and they have to really have this kind of be in charge, kind of command, the buck stops here type mentality. But obviously that can get pretty dangerous if you wind up with a thick skull in terms of going around that. So you have to understand that you don't know it all, and there other people can help you and are more expert. And the people that I've seen over the years have the most success are people that open themselves. Even when I was in hospital medicine, you have this opportunity, especially where I practice at a place like Cedars-Sinai. Some of the smartest people, the most capable, talented people in the world in certain specialties, and of course, I would consult all of them. I would hyper consult on cases. If there was even one question about something I didn't understand and I couldn't get to the answer, then I would just get a consultation. Why would you not? It's only a couple $100 to the healthcare system to have this expert give an opinion on it. And it may save the patient's life. It may save additional morbidity. And actually, I was able to show that with additional consultation, my outcomes were better and the total cost, the total spend was less when you got additional consultation from experts. And yet you would see doctors that would over and over again not have any consultation whatsoever on their cases. And I always wondered about people like that.
Well, from my point of view, I have to tell you, so I have my own basketball reference. Okay. Get ready. Okay.
Okay.
I think we're a dream team. Okay. Right? Isn't that from basketball?
Yeah, that's great. Yeah.
So
What year was the dream team?
What year?
92.
94, 92?
92.
Oh, it's the Lakers, right? The Lakers.
No, it was the Olympics.
Well, you're thinking of the Olympics dream team.
The Olympics dream team, right? Okay. So anyway, and the reason why I think we're a dream team, and it's not just William and I, it's just all of us, really. The Biography Health team, we're a dream team because, scientists and geneticists cannot do it alone. Like we want to make a difference in patients' lives and people's lives. We have to have a support from medical community, because we can't order tests, we can't see patients, and there's a reason for it. We really shouldn't. So this information needs to be processed by doctors. And I also have no problem with skepticism or and I just want the doctors work with doctors who understand their limitations. I understand mine. Okay, I'm not going to participate in clinical care. But that they listen, and they're open-minded, and they look at data, they listen, and they look forward, and they also realize that their paradigms are changing, and they're changing every single day. And you need to do this, or you'll be behind, and your patients are going to be worse off because of it. So to provide the best care, you should be on forefront. So that's why, and I think William, Dr. Stanford is the person who understands it the most. Okay, and he's been doing this for a number of years, which is great.
And for those that are open-minded, wanting to learn more, what are some resources that you would share? I guess both of you can add to this conversation, but resources that both of you would share to the audience that is listening to further their understanding.
Right. So the resources that there are multiple. So I personally follow multiple resources. Most of them are very geneticist oriented, and but there's also something called the Genome Web that I find much more open to with pop. So it's they still share the publications, but they handpick them, and they have a really great interest in bringing the polygenic risk and looking at the studies that look at populations that don't concentrate on the details, and nitpicking on, I don't know, additional variant in additional gene. Again, that's published in like one family in the world. And trust me, I published those families. This is interesting. This is great. Like as a geneticist, it's fascinating. But as a tool in clinical care, it just isn't. So that's why they concentrate on things that are of interest for actually, bigger community and perhaps all of us, and definitely the providers, the medical providers. So yeah, it's Genome, GENOME Web, WEB. So you can get a free newsletter, and you get it every day. So,
and I'll include that
like Inside Precision Medicine. Inside Precision Medicine is a newsletter, also a little more clinically oriented than Genome Web. I like Peter Attia's podcast called The Drive. I think you can get access to some of it for free, and then if you want a full subscription, it's a little bit of money. I like that. There's a free publication called, I think it's just Gen Engineering. It's like GEN, short for genetic engineering, that you might think is just about gene editing and the like, but it also tends to be more clinical, which is the thing that's most useful to say myself and other physicians. In terms, yeah, go ahead.
Eric Topol. So everything that he produces, he's a geneticist. He is, he has a.
You said Eric Topol?
Yeah.
He's a geneticist?
Yeah, I'm pretty sure. Yeah.
He's a cardiologist also. So
yeah, but
I didn't realize.
No, he is. He definitely is. He was part of Scripps.
Yeah, he's excellent. He's excellent, and he's one that also you can get a bunch of free stuff, but he also has a Substack you can subscribe to, and just about any time his mouth is moving, you want to be listening.
Absolutely. Right. Yeah, I agree. And of course, Francis Collins. I don't know if I don't know if he has but I would believe everything that man says. So he's used to be a head of NIH, and before that he was a head of Human Genome Project. He's a great geneticist, so definitely an authority.
He's good.
Yeah.
Did we mention Perlmutter?
David Perlmutter?
Yeah.
No, he's good. I like him.
Okay.
Especially, he's a neurologist really tuned into what Peter Attia calls medicine 3.0. They're very tuned into being proactive and preventive. In the field of neurology, I think he's a neurologist, and forgive me, but I think he's also boarded in integrative medicine. So he has a kind of a more holistic, progressive view. And he's another person I really enjoy listening to give you an idea of where the field of medicine is moving.
Awesome. Well, Dr. Yelena, Dr. Stanford, I really appreciate your time onto the podcast. This was a very insightful and informative podcast that we went through several different types of conversations. So thank you both again for sharing your thoughts and perspectives. I had a really great time.
Well, Taylor, you killed it as always. You killed it as always and lived up to your moniker of Mr. Smooth.
Fantastic experience. Thank you so much.
Thank you. Can't wait to have you back again for another episode. Thanks for joining us on the Precision Medicine Made Simple podcast. If this episode inspired you to learn more about your health, please leave us a review and share the podcast with a friend. Your feedback helps spread the word about the power of precision medicine. Remember, taking action today can lead to a healthier tomorrow. See you next time.